seats, don't we? Yeah.
Well, I'm watching.
Okay, all right, you watch. I'm gonna not do that. Okay. This is how many copies of this fabulous pamphlet I have. It is not such fun to download and print out. It just doesn't feel the same. So if you want a copy, I'm leaving these postcards up here. I will give out what I've got with this caveat. Could you please fill out the postcard and send it out for the copy? They're free. I don't know why. Make a donation. Make a donation. They're free, and give me the extra copy that you get. Okay? Because it's nice to have a supply of these for people who are wanting it, interested in it, needing it. Got some new faces here this morning. Anybody have any questions before we start? Postcards are here. These are the two books that I have used a lot. Sam Harrington's At Peace, Choosing a Good Death After a Long Life, and The Art of Dying Well.
Are they in our library?
And they are now, is Nora here? Joe, Nora ordered these two books. Do you think they came in? Yes, yes, they are. As
But I
are,
haven't been put out, I don't think they put out.
They are. I just saw them.
they are in the library and on display, as are two copies of this. But you can't use the library copies for your personal notes. Okay. Where am I? Okay. I think I want to talk a little bit about the changing title of today's presentation, which started out as resisting the momentum to treat, achieving a natural death, or an over-medicalized death. So the original title, Resisting the Momentum to Treat, was on the calendar of the program that I gave to Jim Clancy. Said, you know, I want to be sure this is okay with you, this program. And he was actually quite enthusiastic about the program, except for this one, which I've now changed. Again, accepting or resisting the momentum to treat. So when Jim Clancy looked at it, it was resisting the momentum to treat. And he said, I want to take this up to PSL. I'm new here. I'm just not comfortable with this. And he came back almost right away. Okay, this is great. Which, to my mind, is the most reassuring thing I've heard in a long time. That means they're okay with us dying. They keep us safe, but they don't necessarily need to keep us alive. Do you understand what I'm saying?
Yes.
So that it's okay to be talking about this and to be thinking about exercising some autonomy over our health decisions, which means our dying decisions. So I personally found that very reassuring. But in the meantime, I'm thinking, I don't want to give you advice about this. I have no medical background. I just have been steeped in this stuff since they had the Hemlock Society 40 years ago. I've been thinking about it for 40 years. But that doesn't mean that I should tell you, you need to resist the momentum to treat. So I just wanted that to be clear, that you guys can make decisions to accept the treatment until you end up in the ICU. That's up to you. Okay, okay. Now, does that stimulate questions? Okay. I have, Dr. Harrington was on a book tour back when he wrote this book. And there's a nifty little very playable video of him talking about this. What? Oh wait, sorry. Whoop. Here's the good news, look at that. US life expectancy has been going steadily up since 1975. It's now plateaued, not surprisingly. Thank you.
That's 25 years ago.
That's the good news. Look at the bad news. Oh, I almost need a laser. Ooh. You see what happens with around
There is one in the
around
basket.
65? What?
There is one in the basket, a laser.
No, it was just a passing sort of. I'm not going to spend a lot of time on this. If I had a laser, what I would do is say, look at that area in there. I've got a mouse. I can. Is that showing up? Yeah. So, you know, our good health declines. This is not a surprise to anybody, is it? So right in here, 75, we start to have not feeling so good. What?
It's England and Wales.
That's because their life expectancy is a little higher than ours, and this is where the chart was. Okay, so we can expect to experience rising levels of disability until what happens? Oh. Okay, the graph ends. Nothing else ends. So here is Dr. Harrington.
At the age of 88, my father appeared to be in perfect health.
Yeah.
And yet there we were, discussing treatment options for a ballooned blood vessel in his abdomen, an aortic aneurysm. If it ruptured, he would die. It would kill him. Now, permanent cure involved major surgery, risking serious complications, and a potential nursing home placement that he dreaded.
After it's over,
Alternatively,
just turn it on.
a temporary strengthening procedure
3.
by outpatient catheterization offered years of life at much less risk. And then he shocked me with this question. Why would I want to fix something that is going to carry me away the way that I want to go? Holy mackerel. Like Woody Allen, he wasn't afraid to die. He just didn't want to be there when it happened. Already wearing a do not resuscitate bracelet, my father's vision was to die quickly, ideally at home. Simple, naive, perhaps. And yet his question demonstrated a vision, some knowledge, and acceptance of a natural death that avoided futile treatment and prolonged debility. Now, I understand the momentum to treat. As a physician, I recommended it. As his son, I wanted him alive to meet my first grandchild. He chose the temporary procedure. My father lived 5 more years and met 12 great-grandchildren. Most of those years were good, but the final one was not. He became progressively weak. He suffered months of debility. He became dependent on others, all things he had hoped to avoid. So, was it worth it? For me, of course. And yet his mantra for that last year was, I have lived too long. When I say decline aggressive treatment, consider hospice care. Some of you think I'm saying, yeah, give up, go home and die. No, I'm asking you to consider the consequences of aggressive therapy in elderly patients. Played out to the end, that results in futile treatment and a painful hospitalized death. So how did my father influence his passing? Well, in the final year, he was advised that his aneurysm was re-expanding, that the risk of rupture had recurred, that he needed another procedure. My father's response was to thank all his physicians and to cancel all his appointments. He entered home hospice, and there, in his words, hoping to wake up dead, he discontinued all medications prescribed to prolong his life, including antibiotics for pneumonia. He lived peacefully and died quietly several months later. Vision, knowledge, acceptance. My father taught me, a practicing physician, that we can visualize an exit strategy. We can resist the momentum to treat. We can embrace compassionate care. At the age
Oh
of
no, go away. Okay, I clicked it down. Is that okay? Good. We have many things to worry about here. All right, so Dr. Harrington asks us to consider the consequences of aggressive therapy in elderly patients, played out to the end. And the real question then is, how do we do that? Ken, could you turn the lights back on? Oh, I actually enlisted. Doesn't hurt to have 3, but. So Dr. Harrington suggests in his book that the default position in most American medicine is to diagnose and treat. Well, I don't think that's a surprise to us. That's the experience that we have, I think. They make a diagnosis so they can develop a treatment plan. They probably also develop a prognosis, which is a nice Latin word for the predicted future course and outcome of the disease. If they don't tell you what that is, it's really important to ask. And it does seem to me still, after 20 years with Dr. Gawande talking about this, and Dr. Harrington, and all the people, all the palliative care physicians and the geriatricians, you still run into surgeons and certain specialists who just don't want to say, you have a 98% chance of dying if you follow this treatment. They don't like to talk about this. It's failure. I mean, Dr. Gawande talked about that yesterday. This feels like failure to them. If you're a surgeon, your assignment is to fix things. If you're an oncologist, it's to help you get rid of your own cancer. So here's the diagnosis. An 80-year-old woman is diagnosed with stage 4 cancer. The proposed treatment, chemotherapy. What's the question that you should ask next? What's the prognosis? How long do I have to live with this if I don't do anything? 3 to 6 months. So take the chemotherapy, right?
No. What's the prognosis with chemo?
Exactly. How long is she likely to live if she does take the chemotherapy? 3 to 6 months more. Is it worth it?
No.
No. Why is it? We know it's not, because the side effects are so horrendous. And yet, we seem to do it. So that's the question that only the patient and her family can answer. Should she take the chemotherapy? The important part is that they ask that question. And that question needs to be asked for a whole lot of things that we're getting treated for, including dialysis. I've just been steeped in some of the medical stuff. The outcomes for dialysis are terrible. And you spend a tremendous amount of time not feeling good, and then another tremendous amount of time in the dialysis place. Yeah. It seemed like such a simple thing. It's like, just clean it out. No. It doesn't work that way. So I thought, turn the mics on, I thought it would be both interesting and helpful to hear your examples of people with a chronic disease that's getting treated, where it worked out or didn't. Daryl, do you mind if I call on you? Because you and I have talked about this.
Sure.
How are we getting the mic back there?
Right here.
Susan and I have talked about an experience I had in, I guess maybe 10 years ago, in that I had 3 friends who had quadruple bypass surgery all about the same time. And I had the power of attorney for one friend who was here in Philadelphia. Like that?
That's great.
Like that?
That's great.
Okay. And he went into the hospital, Pennsylvania hospital, for chest pain and didn't come out for 7 months. He was in the hospital for about 3 months and had a terrible experience with infection, not only of his surgery scar, but also from other secondary infections in the hospital. And then he went to physical therapy for 2 months.
So now we're at 9 months.
No, let's see.
Okay.
I said 7 months overall.
Oh, okay.
3 months in the hospital, 2 months in physical rehab. And it wasn't, I'm sad to say, a very good rehab. And then 2 months in a rented apartment in a retirement community with round-the-clock aid. And so that was really an extreme example of, I think, what can happen if in surgery, even if it's done in a good hospital with a good doctor. And after about a year, he recovered.
Fully.
He was about 75 at the time.
Ah.
He recovered and went on to have a very successful career for the next 7 or 8 years. I had another friend in Los Angeles who actually had a very good doctor at a very good hospital and had the same experience with the same kind of infection and the same kind of length of time in the hospital and treatment. And he also, at the age of 75, recovered after about a year and had this continuing his successful career. I had a third friend in Boston, covering the geographical points, I realized.
All with pretty good hospitals.
Who went to a good hospital with a good doctor. Had a really good experience. He was really not in the hospital very long. He went.
Wait, how old was he?
He was about 75.
Okay.
He went to the rehab facility, looked around and said, "I'm not staying here," and went home. And his care was managed by his doctor and a network of friends. He was in a very good physical condition to start with, and it took him less time to recover, more or less, to where he was before. So that's
I don't know what the moral of that story is. It's the rehab that gets you. So these are all somewhat younger than us, 75-year-olds. We do have one story. Yes.
I have another story that I have.
Oh, okay. Daryl's on a roll.
Really, really horrifying.
Oh, okay.
I had the power of attorney for a dear old cousin and her husband who lived in Arkansas and were in their 90s when they had an automobile accident and then were put in a nursing home. My cousin died and her husband lived on, and he had a stroke, and so mentally he wasn't very present. But he had restless leg syndrome, and he contracted gangrene. He developed gangrene. And hold on to your seats. The surgeon called me and proposed amputating both of his legs.
Oh, jeez.
That would take care of the restless leg
That
syndrome.
would take care of the rest. And needless to say, I said, no, we're not going to do that.
So did he die of the infection then?
Yes, he died of the infection.
We do have one wonderful story in-house of a 90-year-old who had quadruple surgery, bypass surgery, and is now walking the halls around. He's with us, which is an extraordinary thing. But he was very careful to say, well, what's my prognosis? And he got a prognosis of 3% chance of dying. Not 97% chance of dying, but 97% chance that this is going to go okay. Now, why is it that a 90-year-old can have this surgery? His heart is very strong. This is all about arteries. His lungs are very strong. His kidney function's great. He's in great shape. I don't think he exercises at all, so this seems grossly unfair. But so there's a 90-year-old who has come out of quadruple bypass surgery. He said he feels that he suffered terribly in the hospital. It was just the worst thing. And I guess he was there, somebody remember, was it 7 days? Anyway, he's fine. He's going to teach in Village College. It's just a remarkable thing. And one of the things that he did, so now I have to tell you his name, is Paul Selbst. He wrote a sonnet on my open heart surgery at 90 years. And I made some copies for you if you would like to read Paul Selbst's wonderful sonnet about surviving quadruple bypass surgery. It's a crapshoot, isn't it? And that's what makes it so very hard. I wonder if you have other stories before I mooch us on along. Sorry, poor cat. I keep moving around.
Oh, that's fine. I like moving.
Well, in the last 8 years, both my siblings have died, one older and one younger. The first one was my younger sister, and she died of a disease that couldn't even been diagnosed until she almost died. I mean, until she was dying, and it was called Creutzfeldt-Jakob disease. Now that's a weird disease,
Yeah.
and it masks itself as a dementia to start with, but then the body begins to curl in around itself. And it was one of those situations where we could see her fading, but there was at no time was there any time for her to make a decision about what to do about this, because nobody knew what it was. And it really was a tragic death. But I will say that my brother died just recently, this last year in November, of Parkinson's disease, and that had taken his toll over 10 years. He had had a bypass, triple bypass in his 50s, and had gone on to be head of Jefferson, family medicine, and ran an offshore medical school for, another 10 years after he retired. But nevertheless, he was 85 as he was dying, but there was no point at which his family or he was not enjoying his life. And even though he began to deteriorate, and the last time I went to see him, I couldn't hear him, and he couldn't speak loud enough for me to understand what he was saying. But we sat there and just laughed and said, here we are, two old fogies sitting beside each other and holding hands, and that's about the best we can do. But what I will say in both of those deaths was that the family came together in a way the next generation has never been closer. And there is something to be said for the younger generation coming together around their suffering parents and helping them. And it does create a family bond that if he stays, if he continues to want to live, or she does, and really welcomes the visits, then I have seen 2 very difficult deaths be a nice closing, seen to the very bitter end.
Right. Did he die in the intensive care unit?
Say it again.
Did he die in the intensive care unit?
He died, actually, my brother, this is really interesting. They were able to stay on their farm because my sister-in-law is a doctor, a geriatrician, actually. And so she,
Excuse me, you must not knock the pole. Really, it's really important. Okay.
my sister did end up in a nursing home in Maine so she could see the ocean. So that was the accommodation for her. My brother was able to stay on the farm until the last 48 hours when he ended up in the hospice house in southern Maine.
He went on hospice. Yeah.
He did go on hospice.
Has anybody attended somebody's death in intensive care? Oh my. Who would like to? Oh, I don't. Diane, can you even talk about this? No. Okay.
So mine was my husband, and at 42, he had his first heart attack. He proceeded to have 3 more heart attacks, open heart surgery. He had a 5-way bypass. From there, he proceeded to get colon cancer once, then twice. Then his kidneys failed, and he was on dialysis. So for the 20 years he suffered from the first heart attack, it was mostly throughout pain. He had a few laughs here and there, and he enjoyed family, but he suffered greatly. And he never asked those questions or...
Yeah. I don't think this is something that we talked about until quite recently. Okay, Kat, while you're doing your walk, Toma's going to get...
I had an assignment as a caregiver.
Thank you.
I had an assignment as a caregiver to be with somebody who was bedridden. And this woman, she liked to watch television. That's about what she liked to do. And at some point, she had an event which put her in the hospital. And the priest at our church was having heart surgery, and so he could not be with her. And so they sent me. The family was there, and they were waiting to turn off the machine because she was not compos mentis at all. And they were concerned that she was going to gasp and fight it, and that her body would not accept it. And the nurse who was there said, no, that's not what happens. And so she was able to talk to them about it. And they did turn off the machine, and she kept on breathing. And her breath got shallower and shallower and shallower, and then it stopped. But it was very peaceful, and the having that decision to turn off the machine, which I did not have to make, thank God. It was
Because the family was there.
The family was there, and her husband was there, and it was very, very instructive to me about the possibilities of dying quietly and letting the machine keep her alive long enough for her family to gather, and then to let her go peacefully.
Yeah. Okay, Caroline.
I have the machine, yes. I'll talk about my time with my partner, Jim. We had lived together for about 20 years, and at the age of 65, he had a painful feeling in his hip, which he thought he had got by overdoing it riding his bike. And he went for diagnosis, and it turned out that a melanoma that he had had removed about 25 years earlier had reappeared absolutely everywhere in his body. This was Christmas time that we got this news, and he had always gone along with the kind of laughing myth, jolly myth, that he was the delicate flower and I was the hardy old hen who would get him through absolutely everything. And I tried my damnedest to do that, but by February he was in hospital and they were longing to give him chemo, but he wasn't actually well enough to receive it. And we had had conversations about, would he want to go on the breathing machine or not? And he decided that if it looked as if it would give him a chance to get the treatment, he wanted the treatment, he thought he was going to get better. And so he, at some point, couldn't breathe by himself and was on to the machine to be breathing. And this was something we had prepared for in a peculiar way to ourselves, which was we'd had a conversation that said, at some point it may be Caroline's decision what happens to Jim. And that's, yes to the breathing machine or whatever. Or what about taking me off a machine? And we worried that although we had health care powers of attorney for each other, some doctor might look at me and say, well, you're not his wife, you can't make that kind of decision. And so we had at that point actually got married. And that was
Purely for medical reasons.
Purely for medical reasons. And of course what happened was that he was direly ill. He was on that machine, and a week later he was still on that machine. And I said, that's enough. I can't have him on this machine any longer. It's not what he would like. And they agreed to turn the machine off. And indeed, it took about 15 minutes before he died.
Oh my.
And that was the time I had holding his hand. But for me, almost the very hardest thing of all about this was that his father, who doted upon him, was still alive.
Oh my.
And
goodness.
his father lived in New York, and he had come to Philadelphia 2 or 3 times during the course of this last 10 days or so. And I had to explain to his father that I really had to do that. And it was for a while. I mean, his father, my father-in-law was a wonderful person, and we loved each other very dearly, so it didn't, in fact, harm our relationship ultimately, but it was another very difficult piece about being able to bring his father through this.
Wow.
And it was, in a sense, a very good job for me to have. But all of that happened between Christmas and the 20th of February. So it was just galloping. And one of the things I remembered was that I think it was Dr. Gowunda who wrote an article, I read it in the New Yorker magazine, I think, and he was writing initially about over-treating some cancers, which should be left alone, and the kind that grow very, very slowly. And if you start treating them, you're going to subject your patient to much more difficult times alive than you would like to.
Yeah.
And he described what he thought were 3 different kinds of cancer. And one was like a little bunny rabbit, and it popped in and out from behind things. A little bit would appear, and then another, if you were diagnosing it was coming and going, the symptoms, and that you really had to watch out to put things together. And there was a kind that was like some, other larger animal, and then there was a third kind that was like a lion that you just couldn't stop. It would be tearing into the person and not leaving that person for a second.
Melanoma, like
Very fast, yes.
Yeah.
And I just had that in mind as I was watching poor Jim in his last weeks of life, which just went so quickly.
Okay, I will have time again, I think. I just wanted to look at Dr. Harrington's chart, the 3 patterns of illness. With apologies, I spent a ridiculous amount of time trying to get this digitized, and then I thought, what, I'll just do a handout. That's the way we used to do everything. And I wanted to talk about the 3 disease trajectories, one of which is a catastrophic disease. That's not even a disease, a car accident. So that's that one. It's called catastrophe. And you're fine and then you're dead. It doesn't happen like that really, because often you're really, really injured and you spend time in the hospital. But anyway, that's his chart. The 2 that I want to focus on then are the chronic illness, which, I don't hold on to statistics, but some incredible percentage of people our age die of a chronic illness. Very few of us die of car accidents.
Right.
And the chronic illnesses are cancer, heart disease, COPD, usual. Should we name some others? What are the others? Diabetes. Congestive heart failure. Vascular failure. Yeah. And the pattern there is you get a symptom, it gets treated. You have a complication, gets treated. So then you go through a little drop and you stabilize for a while. You have a plateau. And then something comes up. And so you get this plateau, decline, plateau, decline, plateau, decline. And that's, in fact, what Dr. Harrington was describing with his father. The aortic aneurysm is, it's a chronic disease, but it got controlled, and then everything was okay for a while, for a long time, actually. And I think everybody in that family was happy that they bought that time, even though if the old man had been left to his own devices, he would have said, no, it's time. I don't need these extra 8 years, whatever it was. And he was really unhappy at the end. So at some point with a chronic disease, you start saying, is it time to stop treatment? Is it time to stop this treatment? And let it go. And opt for hospice, palliative care, symptom management, no pain, comfort. Okay, but the one that was sort of interesting to me, and I don't think this map quite accurately gets it, is that he calls it diagnosis of old age. And you're just kind of, Well, yeah, we see that here, don't we? Suddenly we're kind of, something's, I'm having some GI issues. Yeah, everybody's got something. And it's kind of, so I want this to be a squiggly line. It shouldn't be just a straight line. It's a squiggly line. I have great days. Everything's fine. But we're not robust anymore. I'm going to be 82 in October. Most of you are in mid-80s. Some of you are heading into your 90s here, huh? Gosh. And I don't know. So Dr. Harrington also counts old age as distinctive trajectory with one smallish thing after another getting treated. So here's some of the stuff that he mentions: fragile skin, peripheral neuropathy. Yes, we see that a lot. I got an email from Jim Delaplane. He's taking the scenic Zephyr to California.
Yes.
And I said, tell me about it. because I think I want to do that when I go visit my kids. He recently sent me a text message. Keep flying. Keep flying. Keep flying. Because, he's got peripheral neuropathy. And so I think, I was picturing him lurching his way along because the train's going. Oh my God. Peripheral neuropathy, exertional shortness of breath, can't quite, short-term memory loss. What am I doing in the kitchen? Damn. And debilitating fatigue, which I actually have seen a lot of the folks over in the personal care spend a lot of time in bed. Well, so do we actually. So minor things separately together cause increasing frailty. Increased medications. Oh. And I remember my husband, John, was diagnosed with Lewy body dementia. And in the somewhat early stages, he was still biking and he fell and broke his hip and he was in rehab. Well, rehab couldn't stand it. They're all the kids in their like 40s and they couldn't stand the fact that he was having some urinary incontinence and urgency. And they wanted to fix that and they were going to train him, pelvic floor exercises. And they put him on oxybutynin. Uh-oh. Well, that's what's called an anticholinergic drug, which none of us should ever take, and that's something you should always ask. I think that the doctors are getting tuned into this a little bit, but it really exacerbated his dementia. So there was so a hip, rehab, treatment and rehab, we're just sailing right down the hill there. Over-medicalization, over-medication. And Daryl sent me the link to the New York Times article about that. It's causing increasing falls. You see that? Yeah.
What was the drug?
It's called oxybutynin. It's great, worked great, except for the dementia. I mean, and so you say leaky bladder, dementia. Oh, well, I'll take the dementia. I don't think so. Anyway, this is the gradual slide into increasingly frail old age of the third chart. Why do I have this here? Discussion. Okay. So,
Susan?
yeah.
Just a comment. You've talked about asking the question for the prognosis. And the only answer
Put that mic up.
that you've given is chance of surviving. I think the question and answer has to go much beyond that. What is the quality of my life going to be?
Okay, I am sorry that I didn't explicitly say that because I thought it should be implicit that if the quality of your life on chemo is going to be, like nausea from 9 a.m. to 10 p.m., you can't sleep, and I don't know. What are the side effects of chemo?
But also, not just during the chemo,
After.
what is going to be the quality of my life afterwards? Am I going to recover to a life that is something I want to live?
Which is why I think that the chronic disease thing is an important one because you can actually chart. The first treatment leads to a slight decline, but then it just begins to keep dropping down, so the quality of your life. I think all of us sort of wish we would have some one really dramatic thing that we can make a decision about, and not all, some of us. Some of us would like something dramatic to happen, so you can make a decision. Want to go on or not? Artists.
What about the quality of life without chemo? That's what happened with my mother. We turned down the chemo, but the remainder of her life was really awful. She was in pain that they were not able to treat for the rest of her life.
I don't know. Did Andrea Barsovic get here? No. She had oral surgery yesterday, and I know sometimes. Yeah. Does anybody want to speak to that?
I'm not going to speak exactly to the last point. I want to go back a little bit to your comment about your husband being prescribed a drug that increased his dementia. By dementia, presumably the neurological dementia that had to do with understanding things. Is that correct? That type of dementia?
Yeah.
So what we have there is a prescription that diminishes your ability to subsequently give informed consent. I think there's a real issue in that sort of trade-off when medicine is actually possibly reducing intellectual autonomy in your decision-making.
Yeah, but you know that no 40-year-old doctor is gonna have that conversation with himself. He says, this guy's got a leaky bladder, he's here in rehab, we're gonna fix that.
And I'd also point out that NIH, according to research my wife Martha participated in, and I think Andrea Barzovic is very aware of, is the whole issue of when a person is communicated with by their physician. And then NIH, long time ago, had ruled that the physician's supposed to tell you what the alternative treatments are, what the side effects of each can be, and how those things can be managed. Now, this does not address exactly the quality of life dimension that Don was just talking about. But I think for a long time, there has been, in the medical establishment, some rules. How well they are applied and honored is an open question, but I think they've really been there. You want to prevent people from not absorbing the information. People remember things they were never told because somebody down the block had a procedure for cancer and they said they're going to lose their hair. And the individual patient sometimes remembers being told that by their doctor, and the doctor never told them that at all. This was part of the research study. I won't go further.
Well, yeah, informed consent.
A lot of what I'm hearing speaks to the necessity. I mean, our healthcare system is so screwed up because we're seeing so many specialists, and I think the important thing is to have a really good family doctor, a general practitioner who can help you in these situations before you make these decisions. Go over a lot of this, because I think to expect someone who's a specialist, you know, in in bladder control or something to make the decision when you have dementia too is asking something that's impossible for particularly the youngest of the crew.
Right.
They don't have an overview, and that's the importance of continuing to use primary care physicians to coordinate your care. And I think a lot of us have a hard time finding that.
But Susie, I was in a situation where I should have said to John, I should have been in touch with John's primary, because he's in rehab. The doctor doesn't come see him in rehab.
Right.
And that's part of the problem, is the compartmentalization. Your PCP doesn't come to you in the hospital anymore. You've got a hospitalist. So everything, yeah, NIH, bless their hearts, but it's not working. It's not happening.
No, I think the system is broken. There's no
Yes,
question.
yes.
But
Which
the
means
family
we-
doctors are still there, but you have to consult them. And even if you have to do phone consults, if you've got a good one that you've been seeing over time, they will take your calls and help you follow all this stuff.
Okay.
But it takes, you know,
It takes agency from us.
it definitely
And
does.
I think that
And
might
that's
be-
why your children are part of this discussion.
Yes, yes.
But you have to include a primary physician or you're never going to get the full picture.
So let me reiterate that, which is, it's really important to ask for informed consent, which means asking some questions, which means challenging a doctor maybe, if not challenging a doctor. So I will tell you this little story. I'm having some GI issues, so I went to see a GI doc that was recommended by my primary care physician. The first thing she said to me is, I'm gonna order a colonoscopy. And I had just read Dr. Harrington's chapter on all the sort of micro decisions that you make. And one of the things that we talk about was a woman in her mid-80s who went in for some GI issues, and they gave her a colonoscopy because they're really well remunerated, you know, and got perforated bowel, which is a terrible thing. And there you go.
Yeah.
Right? And so I had just read that, thank God, because I'm not usually a real pushy patient. This feels pushy to me. I said to her, I'm not going to do that. And so I said, what's next? And she said, well, let's try some medication, which is what we're doing. I thought, really, isn't that interesting? That was the first line of, yeah. Yeah. And it did require me to be somebody that I'm not, actually. So maybe that's partly what I'm asking you, is to try to think about this in terms of the questions you need to ask, the challenges you need to pose, the informed consent you need to seek. What happens? What's the quality of life after this treatment? Is it going to be better or worse than the quality of life I have now? For how long? And the thing that we talked about yesterday, and we'll talk again about tomorrow, if you can't do this on your own, and lots of people won't be able to do it on their own, your family's got to represent you. So tomorrow, that's what we talk about. Again, it's like, how do you have this conversation? And partly, I think what we're doing here is having the conversation. It's like, it's okay to talk about this. Why don't we talk about it at dinner sometimes? So, where are we? Anything else? Yes, Nancy.
I understand the complexities of dealing with medical professionals. I just want to say that in more than one instance, I've had, when I'm relating to a family member, I've had a very helpful medical professional who says, I don't think you should be doing this. When my mother-in-law was dying, actually this was her grandson, my nephew, who came in and said, I want to see the chart. And he looked at it and he said, why are they giving her this? And he called in the hospitalist and said, stop. So I think there are medical professionals who are getting this, and let's really hold them up and support them and encourage them. And maybe some of the younger trained doctors are more along those ways of thinking. I'd like to hope so.
Yeah, I think that the people who tend to be the super specialists, and they've got maybe one way of looking at things. Yeah. Any other thoughts about this? The importance of getting your family involved? Yes. This is Charlie Day's daughter. Sister. Oh, she looks great.
All right.
Oh, sorry, Charlie.
So I am an internist. I practiced for 40 years. I've been retired for 5 years. And I agree there are many things broken about the system.
Hold that mic right up to your mouth.
I agree that the system is broken, but there are people that you can talk to. I just wanted to kind of put some thoughts together, which is I, for many years, had conversations with patients about how they felt about things. And if you're at one point in that curve, you have certain feelings about what's an acceptable quality of life. But that can evolve as you go step down the ladder and your vision changes both ways. Also, if you talk to somebody at 74 who's about to go in and have bypass surgery, they're feeling pretty good. They're going to say, yeah, go for it. If you go and talk to them in rehab and they're like, this is horrible, get me out of here. So people's opinions and how they feel about their quality of life evolve. It's not a static thing. So it's really important to have ongoing conversations and people you trust, and also talk up for yourself, because your family may not know how your feelings have evolved. Your doctor may not know how your feelings have evolved. And it has to be a dialogue that goes on. And so that's what you're getting to tomorrow, I think. But I think
well, exactly. I think that the idea is, you guys informed me that they now require an advance directive for you to come in. But after you've been here for 5 years, does it still say what you want? Did you have to fill out an advance directive to come live it? Irma says yes. Yes, okay. So We didn't.
No.
I've been here 10 years. We didn't.
I think if you have the A plan.
Well, I can.
I don't have the A plan.
Yes, you don't have to fill out an advance directive and for right?
So I guess my point is that they need to be updated
Yes.
regularly. Yeah. Not only does our health change, we change. And I think one of the things that I have become more and more aware of in the last few years is how much that change can happen where, you know, my sort of boomer self it's all about control, agency, cognitive capacity, being able to organize things. Well, maybe I could just subside a little bit, spend a little more time listening to music, taking more walks, sitting on the patio looking at the trees and saying, oh, this is great. Life is fine. I asked one of the folks over at Personal Care who had moved over there quite recently, and it isn't doing particularly well. But I know her well enough to say, are you glad to be alive? And she said, yeah. It was a tentative yeah. I mean, she's not happy. And I don't think that she's going to be. I don't think there's going to be one of these. I think it's going to be one of these. Because that's how it works. But apparently the things that give us pleasure, and then we're back to, you know, how do you want to die? But Atul Gawande's, what's a good day? What's a good day? And that's the other side of the coin. Okay, tomorrow we'll talk about conversations with family and how important that is, but you can see how nothing, it's all a big ball of stuff. It's all connected and raveled up. You can turn your phones back on.